Dr. Arup is the director of Chakrabarti Eye Care Center, and I can go on this all evening and all night talking about him. He's a dear friend of mine, a senior of mine. I still ask him for a lot of tips and tricks, and he has trained many people, a lot of presentations, a lot of papers, a lot of books. He's a chief instructor in many good courses in India, US, AP, ACRS, and the works. So I think all of us know about him. Let's not waste time talking about him, but see all those wonderful things that he has to show for us today. Over to you, Dr. Arup.
So, good evening, friends. This is Arup Chakrabarti. Thank you, Ashok, for the very kind introduction. Ashok actually has been a very, very good friend, and he is a very reasonable man. He's a good surgeon. He's rational, and many a time I ask him if I have any clarifications on a lot of issues pertaining to practice or case management. So he has asked me to talk on two topics. One is phaco in posterior polar cataract, and second one is healthy habits for unhealthy endothelium. Okay, so let me start off with the first presentation. So, I have been doing post-polar cataract from the early 1990s, and at that time there was not much available in the literature. The techniques and strategies were just developing, so I sort of evolved. Now, over the last 27 years, and I have got my own strategy in place, and I've been using it for about 25 years with very good results. And the main challenge here is the occurrence of posterior capsular end. It may be pre-existing, we call it congenital posterior capsular dehiscence. It may occur during hydrodissection if you perform a cortical cleaving hydrodissection or an inadvertent cortical cleaving hydrodissection. Nucleus cracking, nucleus chopping, vacuuming of the posterior capsule, traumatic bagging of the trailing haptic of the intraocular lens. In fact, I have encountered PC rent in all these situations. And I have recently seen videos where it occurred during stromal hydration. I'm not sure whether those were cases associated with flax, where there's a trauma to the injury to the posterior capsule because of flax. I'm not very sure about it, but that is also one of the possibilities. So these are some of the cases. Clinically, they're not very difficult to diagnose. All of these patients had open posterior capsule. This is the spindle defect that you see, in addition to the holes that you see here. The white powdery deposits. There are oil droplets-like structures on the anterior vitreous. Tri-radiate extensions. All these patients actually had a posterior capsular end, and none of them had any vitreous disturbance. They already had a pre-existing PC rent. Now, in certain situations where you have a brunescent nucleus and these things may be concealed, all these posterior capsular polar findings. So, if you look at the fellow eye, you will see either it is aphakic or it is pseudophakic with a PC rent and vitreous intersection. So then you can assume that you're dealing with a challenging posterior polar cataract, and you need to evolve your strategy. See, over the years, there have been a lot of diagnostic imaging publications in the literature, high frequency ultrasound using 25 or 50 megahertz, Schimflag imaging, antecedent OCT, intraoperative OCT. And all these things are good. There have been very nice publications, brilliant publications, and very, very nice pictures. But if you are not using all these in your practice, please don't belittle yourself. Don't feel guilty that you're not delivering justice to the patients, because whenever you encounter a patient with posterior polar cataract, there is no discrimination. All posterior polar cataracts can lead on to PC rent. This should be our mantra, and devise a surgical strategy accordingly. So I have a separate strategy for soft cataract, soft posterior polar cataract, and different one for hard cataracts. So let me focus on hard cataracts today. So this particular gentleman is in the mid 60s, and this just shows the surgical technique. And the next one is one where I'm going to have a complication which was well managed, and patient did well eventually. So here, since hydrodissection has not been done, so I cannot rotate the nucleus. So I'm going for a direct chopping with the Chang chopper. So the nucleus is elevated slightly, and then the chopping is carried out. Here the game plan is on the nasal side. I want to chisel out a big chunk, weight-shaped chunk of the nucleus from the parent body of the nucleus, thereby creating space in the central and the inferior and the nasal capsular bag. All this lateral separation that is happening is at a more anterior plane in the capsular bag, so there is no transmitted force going across the posterior capsule. Since I am not able, since I should not be rotating the nucleus, so I just tilt the phaco handpiece, and I get an appropriate, almost 4 or 5 clock hours here, appropriate chop, and then I have a big chunk of the nucleus which is emulsified, and then we thereby I have more space. You'll be seeing in the central and the nasal part of the capsular bag. Then again, I tilt my phaco handpiece. It brings the rest of the subincision and nucleus in a more accessible, the deeper aspect of the central of the anterior chamber. You have to use a lot of cohesive, dispersive OVD to protect the corneal endothelium. It goes without saying. Not only because it's a hard cataract, but because you're performing manipulations at an anterior plane. So everything goes up pretty well, and patient had done well. But now this is the case that I wanted you to see. This was a man in his mid-70s. Fellow eye, similar finding. I have done almost a decade earlier. Everything went off fine. So I perform a hydro-free dissection. I don't believe in any hydro steps in post-polar cataract. Here I have made a triangle, a base is towards the nasal side, apex subincisionally, so you have a vertical wall. And it is, because it is a harder cataract, so I want to start chopping from a deeper plane. Same strategy that was demonstrated in my previous case is being shown here with much, so the chopping happens very smoothly. Now, why I do not use a hydro steps here, even if you do hydro delineation, you can have an inadvertent hydro dissection that may rupture the PC. So I think that led on to the genesis of the inside out hydro delineation, just to avoid accidental hydro dissection while performing hydro delineation. Limited hydro dissection also doesn't make much sense, because how do you limit? I don't understand. So by separating the capsule, you basically break the cleavage in the adhesions. So the fluid sort of seeps through as you do phacoemulsification under the capsule, and goes behind in a slow manner, so that the posterior capsule, so that there is the nucleus is mobilized. Now, as I remove the last chunk of the nucleus, I noticed that there is a small PC defect. I'm using hydroxypropyl methyl cellulose, and now I realize that I should not have done that. So I go with bimanual irrigation aspiration. The cortex is started removal from here. And here is again another thing that should not have happened, because the PC rent is located here, and I should have focused entirely on removing the cortex from this area, the area farthest from the PC rent area. And then the irrigation also should not have been brought here. This is a mid-70s gentleman, so his vitreous is also liquefied. Antravitreous face is not very condensed. So I had a PC rent, and then I injected the HPMC again. And before I removed my handpiece from the other side port, injected triamcinolone acetonide 1:2 to dilution. Now I dilute it a little bit more, because subsequently vitrectomy has to be performed, and we have no business to work within the anterior chamber with the vitreous strand being there. So a cutter, so I am performing a bimanual limbal vitrectomy, and my initial plan was to use the same cutter, irrigation aspiration cutting mode, because I have a dual linear foot pedal machine with those features. So it is not happening well. So I decided to change my strategy. So instead of that, I injected OVD again into the anterior chamber and went for dry cortex aspiration. So that worked pretty well here. By this time, the PC rent has enlarged significantly. So now I go with my hydrodissection cannula, strip off the cortex from the fornices, bring it to the subincisional area, and then aspirate whatever is there. So the cortex is removed, working from the side port from the main incision. Before the intraocular lens goes in, again I stain the anterior chamber with triamcinolone acetonide, 40 milligram per ml, diluted 1:2. Compress the capsular bag in the periphery by injecting HPMC or whatever OVD you have. And then I use the 3-piece hydrophobic acrylic lens. The leading haptic goes into the sulcus. Make sure that it doesn't dive down through the PC rent. Then you will be dropping the lens in the posterior segment. So this has to be carefully done. The trailing haptic, again, I don't dial. I just compress and push it gently, tuck it gently under the iris. The lens is kept in a different meridian. And so afterwards, I will be achieving posterior button holding of the optic to the capsular axis. So sulcus is not a very stable place for a 13 millimeter lens, though better than 12.5. So once you lock the lens in place through the optic capture, it stays very stable the postoperative period, rest of his life. So this patient has done extremely well. So this is the postoperative view. So friends, in conclusion, while dealing with post-polar cataract, you must ensure that the counseling is properly done. Patient must be aware that what are the potential complications. And the patient should also be informed that the surgery may be done in the second sitting if there is a drop nucleus, or if you don't have the standby intraocular lens, should you require a standby lens. Customize the surgical strategy and phaco-parameters depending upon the findings in the given case. No cortical cleaving hydrodissection, so I do hydro-free dissection. No hydrodelineation, no inside-out delineation, though it works well in many surgeons' hands. Maintain deep AC at all the time. All steps of the surgery must be adept with the anti-vitrectomy strategy, and you need to maintain a necessary IOL inventory. So this brings an end to my first talk. Do I have time for the second talk?
Yes, you have. Yes, please.
Okay. So am I on the screen? Can you hear me?
Yes, I can.
Right. So actually, this is part one of the talk on cataract surgery in eyes with unhealthy endothelium. Sujata will be talking, completing the talk in part two. Thank you, Sujata, for that. So, we need to have, even if the corneal endothelium is not very clear, we need to have a pristine cornea on post-op day one. So you have to take certain steps in the preoperative period, intraoperatively, and the post-operatively. So I routinely perform a very thorough slit lamp biomicroscopy and examine the corneal endothelium under the zone of specular reflection. And there are certain predictive factors for post-op need for endothelial keratoplasty. So I'm not going into the details of that. So I always inform my patients that, at some point in time, you may require an endothelial keratoplasty, and the patient has to be informed before you take up the patient for surgery. I also perform a specular microscopy, and all these things are done. And many a time I have seen patients with pseudophakic bullous keratopathy in the fellow eye. And when I saw the patient on slit lamp, I realized that this was a patient with fugues, and maybe the earlier surgeon hasn't done the proper corneal endothelial evaluation. So pachymetry is something which we again routinely have to do for all these patients. And there is a cutoff value for the pachymetry, 630, 640 microns. And here, these corneas are not very healthy. So I'm not a big fan of using a lot of oroquine eye drops for them. Povidone iodine also tends to make these corneas a little hazy, and because you want total clarity. So I really depend upon the LOX2 jelly in these situations. You have to make sure that the povidone iodine is totally washed out of the eye. I mean, I use it very rigorously, and at the end of this, before it enters the eye, you must ensure that the entire povidone iodine would have been removed from the conjunctival sac. Some of these cases, I would do a scleral tunnel rather than a clear corneal incision. Use an appropriate OVD strategy. You see viscoat, Hilon 5, Hilon G, everything has to be there. And this step is dependent upon viscoat. And some surgeons also believe in using BSS plus, though I have never used BSS plus. Use a soft shell technique or the tri-soft shell technique, wherein you inject BSS under Hilon 5. And recently, I came across this paper, actually, May issue of JCRS. See, the anterior chamber maintenance are becoming very, very popular. And this is a study published from Egypt. It says that surgery with the OVDs deprives the endothelium preserving effect of the OVD. And so anterior chamber maintenance should not be used during phaco in patients with limited corneal endothelial reserve. Do a small rhexis. Make sure that all your manipulations happen within the capsular rhexis. The nucleus should not pop out of the capsular bag. All the manipulations should be endocapsular, so chopping definitely helps in this situation. And as regards the surgical technique, use a technique which works best in your hand. So if it is a direct chop technique, that's fine. If it is stop and chop, which you're very adept at and it works well in your hand, that is fine. So make sure that you do not put the phaco energy to judicious use. I would rather be using torsional phaco in these kind of patients because it is very easy to use high power in harder cataracts without damaging the intraocular structures. Avoid instrument touch. For example, here there was AC collapse and the instrument touched the endothelium. Nucleus shatter is something which can have disastrous effect if you're dealing with a patient with a borderline endothelium, because this ricochets on the endothelium, it damages the corneal endothelium. So make sure that you are we don't do that. Avoid a hydrophilic acrylic lens, because post-operatively, if these patients go for dissect or demake, when you inject air, these lenses may have opacification. So that hydrophobic acrylic lens is the lens of choice. Always aim for -1 to -1.5 diopter myopia, because a hyperopic refraction is seen in DSEK as well as the DMEK. So initially people thought the DMEK is going to be neutral as far as refraction is concerned. There's a postoperative hyperopic shift is seen. Patient with Fuchs dystrophy, a corneal guttata, I will not be using multifocal lens, because as such, the corneal guttata will reduce the contrast sensitivity because of scattering of light. And I don't want any additional loss of quality of vision in these advanced technology lenses. So friends, these are the indications for performing only phaco in Fuchs dystrophy, Pachy less than 640. I prefer to take them up before the nucleus is too hard, protect the corneal endothelium at all cost, and this kind of cases should be done by an experienced surgeon. These are some of my cases, and they do extremely well if you have taken the proper precautions and done a good surgery. Thank you very much for your kind attention.
Thank you very much, Dr. Arup. As always, excellent talk and a lot of take-home messages there.